Opportunity for presentation, and thanks everybody for joining us tonight. I would like to open up the presentation, and my name is Dr. Chitra Parab, and I'm the developmental pediatrician working with Southeast Sydney Local Health District. And we have three presenters tonight. I'll be starting the presentation with developmental issues among preschool and school age group, essentially around intellectual disability. I'll be followed by Kathy Sibonis, who is a senior social worker on the Specialist Intellectual Disability team. And she will be discussing about impacts on the family of having a child with disability. Kathy will be followed by Dr. Asma Taskin, who is a rehabilitation physician staff specialist working with the team. And she will be talking about transition into adulthood, what happens after the school and how can we assist these children and families with disabilities transitioning into adulthood. And there will be an opportunity for all the attendees to submit the questions by typing them in the questions tab on a screen. And at the end of the presentation, we will try and answer the questions. Now, let's get started because with the evening, there's a lot of matter to get through, and we will see how we can be as comprehensive as we can. And if there are any queries, please feel free to contact us even after the session, and there will be contact details at the end of the presentation if there are any queries which do not get answered tonight. First slide. That's the opening page. I would like to start my presentation by saying that all children are individuals with their own strengths, challenges, likes, dislikes, and personalities. Like all of us adults, no one adult is like another. No one child is like another child. And we should identify them as individuals. They need love, care, and support to reach their fullest potential. And it's like a raindrop falling from the sky. Whatever small assistance we can give, all of us, health professionals or support workers, it is all contributing to the family's welfare and to the child's well-being. Firstly, outline of my talk. I'm first going to open up by talking about certain diagnostic terminologies, developmental and intellectual disability. Then I will talk about prevalence, etiology, and specific genetic syndromes. And not the least, which will be followed by, I would like to give some take-home messages, especially when you see these children and families in your outpatient clinics. And autism spectrum disorder, which is sort of the common favorite topic of the decade. So just an overview on that. So developmental terminologies and assessment, broad word. Let's see if we can unpack it. When we talk about diagnostic terms, obviously there needs to be some consistency or some evidence-based guidelines and terminologies which we as clinicians need to refer to. And these are two diagnostic manuals / Bibles in the field of developmental medicine and mental health. The first one is Diagnostic and Statistics Manual, which is 5th edition, which was released in 2013, which is American Psychiatric Association's manual, which gets followed in most of the countries, including us in Australia. Majority of us follow DSM-5 manual for diagnostic terminologies, following diagnostic criteria. The other equivalent manual is International Classification of Diseases, 11th edition, and that's World Health Organization manual, and which was released recently, June 2018. And there is, most of the time, there is overlap across both manuals with some specifications. As I said, unpacking developmental terminologies, It's interesting how all these words get used, or terms do get used interchangeably, not only among the families, but also among the clinicians. So we can imagine the confusion it may cause. So first, developmental disability, which is a broad umbrella term, and all the disabilities do fall under this umbrella term. And the term disability is self-explanatory, dis and ability. So basically, if the child or an individual is unable to perform up to his capacity or expectation, that is dis, up to his ability, child is not performing. And then global developmental delay, intellectual disability, and many other disabilities, including cerebral palsy, many other motor defects, learning difficulties, hearing vision impairments, and many other, they fall under that umbrella. I would like to say here, when we say developmental terminologies, we try to classify developmental phenotype or a pattern, what we see. The under etiologic diagnosis can be a separate term which is added along with this developmental diagnosis. As I said, developmental disability is a broad term, and DSM-5 manual doesn't capture it, but it still gets used in the routine clinical environment. So basically, since it's broad, it doesn't have more specifications, but it comprises a group of conditions which can cause impairment across many developmental domains and usually last through a person's lifetime. As mentioned in the previous slide, developmental disability then gets branched out into different terms, but the common ones are global developmental delay and intellectual disability. There is somewhat overlap, which I would like to explain, and distinct differences as well. Yes, there is an overlap, but one needs to know what are the differences. So global developmental delay is the term which we use in children less than 5 years of age as per DSM-5 manual. And we use it when the child fails to meet expected developmental milestones. But how much is the delay? It has to be significant, and significant is more than 2 standard deviation as per standardized assessments. But at the same time, at times, we do not have access to standardized assessments. So based on clinical impression, this diagnosis does get formulated by single clinicians, essentially pediatricians. And significant functional delay across 2 or more developmental domains. And another thing which I would like to say, the clinical severity, this term gets used when we are not able to quantify reliably the severity of the level of delay, or the child is unable to undergo an intellectual functioning assessments. And global developmental delay is a diagnosis in transition, I would call. It has to be reassessed to work out whether really is it progressing into intellectual disability, or the child is performing into borderline or low average intellectual capacity, but has an added baggage with some other impairments, but which are not progressing to developmental, not progressing to intellectual disability. Global developmental delay, as I said, the diagnosis could be done informally in the pediatrician's rooms by interview, collating reports from therapists, observing the child. In addition, when there are significant impairments, then some cohort of these children do get referred to developmental assessment team, which I'm part of at COGRA Diagnostic Service, in addition to working in intellectual disability team. And here, in addition with the psychologist and other allied health professionals, such as speech therapists, which is currently on the team, we do undertake Griffith's developmental assessments. But at the same time, and Bailey's assessment is also available. Yes, standardized assessment tools are available, but we need to use it judiciously, and only we have to be conscious about which children need to go under assessment. The delay has to be significant, and it has to be across the developmental domains. We do not try to put kids under the assessment who show individual developmental domains like language skills isolated issues or isolated coordination issues or fine motor difficulties. Let's move on to intellectual disability. What's intellectual disability? Before that, what is intellectual functioning? So on left-hand side, a number of higher order functioning, which we all do in our day-to-day life, have been listed. On the right-hand side, adaptive functioning, which includes concepts, how we interact socially, and practical day-to-day problem solving outside. So when one has to come to a diagnosis of intellectual disability, one has to combine findings on both assessment. Not an isolated intellectual score can define intellectual disability as per DSM-5. And that's very true. Just based on single number, one cannot define the predictability of the child's functioning. It has multiple domains. And these limitations, generally, intellectual disability is clearly specified. Impairment has to be during early development period, that is childhood or adolescence, which is different from acquired etiologies of intellectual impairment. This is a Gaussian curve which shows how all of us in this population are spread across, I would say. Let's see which part of this gets classified as intellectual disability. Where my arrow is currently, that's most of the population is in 67% of the average. I'm not talking about the right-hand side, that's high average, superior, gifted. Let's go on left-hand side, which is low average, then borderline, and then comes the extreme 2.5% half, which is classified on any standardized assessment as extremely low functioning. And that comes under intellectual disability / developmental delay or significantly low scores on adaptive functioning. And that gets further classified into mild, moderate, severe, and profound. This is a slide. It's merely academic, but I thought I would still put it here in terms of the names of intellectual or IQ tests, intelligence tests. WIPSI, Wechsler tests are generally used, and a psychologist is a clinician who is generally accredited to administer it. There are, in addition to Wechsler, there are other tests, Stanford Binet and differential abilities tests. And generally, psychologists do make a call based on child's verbal skills, which test generally gets used. Wechsler skills are generally for children who have some functionable language skills, who can give a fair go at attempting at this test, and fair attention to task skills, as compared to other tests which do get pulled out when we are seeing significantly low functioning kids where attention can be a challenge. The commonest scenario is autism spectrum disorder kids who are starting school, and we need to give accurate reflection of them of their functioning. Now, a blurb on intelligence test. What intelligence tests are useful for? They show good predictive validity, relatively stable scores over the lifespan. And another thing, 0 to 5 years is the age group where things are not fixed, pliable. In fact, the concept of plasticity is quite widening, but still 0 to 5, there is a lot of potential for shift, especially when there are a lot of environmental factors. If there are biological issues, it can be tricky, but that's why the IQ tests generally get administered from age 4 to 5 onwards, even though one can do IQ from the age of 2.5 to 3 years. Generally in clinical practice, translation is just prior to starting school is the time when we attempt intelligence tests. Prior to that, generally developmental tests gets attempted. And what does IQ doesn't measure? The IQs do measure verbal processing, non-verbal processing. The IQ also measures working memory. Working memory is short-term memory, how much you can hold, and at what speed one can process the information. But IQ is not everything. There are many other aspects of higher intelligence, like planning and executive functioning, social awareness, child's temperament, enthusiasm, child's attention to task, impulsiveness, anxiety, and personality and coping skills. So they're much, much more than IQ, but still IQ is a good benchmark to start off with. Moving on, adaptive functioning assessment. I've just pulled in two different booklets which we generally use, Wineland and Abbas. The one thing which I would like to highlight, the information can be gathered from different settings, either home or parent, and as well as educators, preschool or school. And generally, clinicians do use their discretion depending upon the information gets received based on who can add the value in terms of their child's observations. And another thing, the information, even though these adaptive behavior skills we use in children, they go up to adulthood, and quite a few disability services do use them in the adults. And in addition to define an individual's functioning, the added advantage is it helps in giving the deficits and planning out the training programs. Intellectual disability formulation. See, any formulation, diagnosis is not just one word, it's a formulation, taking multiple information into account. One has to take a good history, take all the information, all the feedback, observe the child, examination, and standardized assessment. So yes, the test comes in addition to all above. And moving on, what are the descriptors? Intellectual disability gets classified as mild, moderate, severe, and profound. This is DSM-5 classification, which talks about what is mild, moderate, severe, profound. I'm not going to dwell into that because there's a lot to be covered, but one thing I would like to say, the extreme right column, what does mild translates in terms of supports needed? Like mild intellectual disability, parents often ask us at the age of 3, 4, 5, 6, when we are talking, will my child be able to go to university? Will be able to child function as an independent adult? It's too hard to predict, but still we have to give them some information balanced with hope, because hope is all on which families live. So, and we can't predict too accurately what the future holds, even in intellectually blessed individuals. But a ballpark is mildly impaired children, definitely as an adult, one is expected, if all goes as expected, they should be relatively independent with some supports. It's moderate when it starts functioning, starts falling downwards. Obviously, the level of support is going to be more. The moderate are the people who are going to achieve some independent living, but they're going to be fairly dependent on adults for their day-to-day functioning. And severe and profound are the individuals who are bound to require, starting from school up to the adulthood, an intense level of support, either for parents, support agencies, and many professionals. Assessment scales. We talked about developmental scales, we talked about intelligence scales. There are many assessment scales which define children's functioning, which I'm not going to cover today because that's not the scope of the talk, but one should know these are generally the tests which gets used in different contexts, especially where intellectual disability is not an issue, but there are higher level functioning, as I said, achievement tests and learning. So the child can have a normal intelligence or average intelligence. Normal is not the word to use, but average is the word to use, technical word, but the child may not be able to apply academically. So that's academic achievement, nonverbal reasoning, behavioral measures. We talk about a lot of challenging behaviors. Neuropsychological is executive functioning, attention to task, ADHD and all that it encompasses. Mood and mental health measures, which as child psychiatrists and even Dr. Adrian Keller psychiatrists would have spoken regarding an overlap of mental health issues and intellectual disability. Moving on to the next half, what's the prevalence of intellectual disability and what is the common etiologies? So I already showed you on the graph that it's left 2.5% of the population, and that's what the data shows, is the prevalence is between 1 to 3%. Males more common than females. Generally, mild disability or mild intellectual is more common as compared to moderate, severe, and profound. Even though on a bigger scale, in any disability service, the severe, profound, or moderate is overrepresented because that's the need for support is more. But if you took at the population level, mild disability is much more prevalent. Australian data is similar. 3% of Australians, around 500,000 million, and out of that, 1.8% of the total intellectual disability population have severe to profound limitations. Okay. Having covered the prevalence, let's move to the what is the etiology and what does the data show us. So it's a heterogeneous etiology. It's not one single cause. And one thing, mild intellectual disability and etiology is unknown in many cases, and environmental influence is quite common. Early childhood is lots dependent on environmental stimulation, and many other general health, nutrition come into play. It's marked intellectual disability where genetic forms the major cohort and trisomy 21 is the commonest, followed by Fragile X. This is the literature reports. And then multiple syndromes, common are Angelman, Prader-Willi, Williams. And I have put some slides covering common clinical features of the common syndrome. I would like to also highlight fetal alcohol syndrome is becoming more and more common over last 5 to 10 years. It always existed, but there's a lot of data, literature is available, quite a lot in Canada, and even in Western Australia, a lot of articles are coming out. More awareness, I would like to say. Maternal infections, obviously, as we have progressed with medical advances, we are not seeing as commonly, but still CMV infections, quite common in terms of their sequelae. And perinatal and postnatal sequelae, we are not seeing that as commonly, but they still exist. And obviously cerebral palsy is one of the diagnoses which will fall into this category, which becomes evident over a series of observations, generally commonly between first to second year, but there is quite a few trend towards if we can diagnose these kids early before first year of life, it is evident. That's where the move is. Etiology, as I said in my previous slide, trisomy 21 is commonest, 1 in 1,500. Followed by Fragile X is the most frequent, X-linked syndrome, because X-linked etiologies of intellectual disability are commonly described in the literature. Fetal alcohol syndrome. I would like to spend a minute on this pie diagram, which shows if you see unknown, so almost 50% of the etiology, 40 to 50%, we don't find an etiology, and that happens commonly in the mild subgroup. It's mainly the severe to profound where genetic causes are more commonly known, and environmental known factors are still present in a quarter. But still there is lots and lots of impact of environmental, and that goes classified as unknown. Genetic testing. It has been an era of evolution. When I was training, karyotype was the only information available, and literally karyotype is just a mirror image of how many pairs of chromosomes one has, 22 pairs, and then a sex chromosome X and Y. This is a slide outlining the chromosome, how it looks. Then came CGH array in last 10 years, where CGH is a micro array which outlines all the chromosome patterns all together. Like karyotype, it just if any whole chromosome is missing. CGH array is sort of if any micro section is missing or is duplicated. That is the era for last 5 to 10 years. Fragile X is specifically for diagnosing Fragile X. Urine metabolic screen, we do it commonly, like CGH array, Fragile X testing, and urine metabolic screen are the common investigations. Pediatricians do order it in any child with significant developmental delay. The addition to this bunch has become a genomic testing. which has become available since start of this calendar year on Medicare rebatable items. We pediatricians are yet to grapple with this, and that goes at further slice level of the exome, and I myself haven't yet caught up with all that technology. So we generally call up a friendly geneticist and have a discussions. And there are multiple levels of slicing is available, and it's a whole new world we are all trying to learn. But it's good to be aware that genomic testing is available. And one thing, any normal previous genetic test doesn't automatically rule out any underlying genetic issues, especially in a population of moderate, severe to profound. Generally, recommendations from geneticists is after 2 to 5 years, new test has come out. So if you think there is still an unknown cause and clinically you want to explore it further, yes, there is a room to reconsider a higher resolution testing, which is genomic testing, but obviously in consultation with the specialist. Let's move on to specific genetic syndromes. Busy slide, please pardon me, but I'll still like to highlight important thing. What's Down syndrome? Non-distinction of chromosome 21. So basically, there is an additional chromosome 21, and most commonly it's diagnosed antenatally or shortly after birth. And there's a peculiar facial features here. Hypertelorism, that is eyes are separated, down slanting eyes, short fingers, single palmar crease. So facial characteristics of Downs is not to be missed. It's pretty obvious. And that's why Downs come into recognitions quite early. These are the children who come with a gamut of associated issues, heart disease, hearing, vision, sleep, gut, spine, increased risk of leukemias. So yes, it's good to be aware that one has to be proactive and screen these children for these issues. One thing is there is an associated learning difficulty / intellectual disabilities, and their strengths are in visual and social functioning, and language and pronunciation are relative weaknesses. Fragile X is next common thing. The thing is, Fragile X always commonly goes unnoticed unless one is clinically suspecting. It's down the track, somebody thinks, and then the investigation gets carried out. The facial features are not that characteristic, but still one can stand out. Broad forehead, elongated face, prominent ears, increased risk of neurodevelopmental issues. Generally, early primary or late primary, kids not performing well, challenges, gets assessed, and that's when the diagnosis starts coming forward. Prader-Willi, quite characteristic. Infantile hypotonia, hypotonic floppy babies, truncal morbid obesity, feeding difficulties. So, and hyperphagia, basically, these are the kids who generally are food seeking. And that causes a lot of comorbid issues. And intellectual disability is part and parcel, mild to moderate intellectual disability. I'm not going, since slides are going to be available, this information will be available to you. I'm not going to read entire information, but one thing, what causes Prader-Willi? And Prader-Willi is basically, these are the children who have 2 copies of maternal chromosome with no paternal chromosome. It's not the entire chromosome, but it's a 15q11 to 13. And opposite is Angelman, where is a maternal copy of the same chromosome is missing. These are like a happy puppet. These are the children, quite happy, but unfortunately, they're not blessed with their intellect. It comes with seizures, ataxia, jerky arm movements, and life expectancy is normal. And variable prevalence, because one has to be looking for it. Otherwise, things always go unnoticed. Williams. Again, these are the kids with mild to moderate intellectual disability, deletion of elastin gene on chromosome 7, peculiar faces, which is called as Elfin faces. They have heart condition and they have typically cocktail party speech, and they're happy chappies. So basically, they're over social. And there's increased risk of ADHD, anxiety, phobias, fetal alcohol syndrome. Okay, I mentioned this is the website where there's a lot of research coming out, and Telethon Kids is in Western Australia, and a lot of data is collected from Canada. There is a specific Australian guidelines have come out for diagnosing fetal alcohol syndrome. It's not a diagnosis of exclusion, but one still needs to have a genetic testing which has ruled out any identifiable underlying genetic etiology. A sentinel facial features are short palpebral fissure. Palpebral fissure is eye, is short, smooth philtrum, that's here a space between the base of the nose and upper lip and thin upper lip. And I'm not going to detail, but there has to be history of significant alcohol exposure, like a prenatal alcohol exposure, and a gamut of tests identifying neurodevelopmental domain function compromise. Okay, we are coming to the almost second last section. What's the clinical? All this information exists. How do we apply it clinically? Early intervention is a way to go because this is cost effective to help the society. For if we can empower all these children and families to reach their potential. That's where the money is and money should be, and we should be informing policymakers. So what's the impact of development on the development of nature and nurture? So biology is what we are born with. Physical health, disability, genetic vulnerabilities. What's our temperament? What's our intellectual ability? Which gets shaped further by our psychological aspect, coping skills, social skills, self-esteem, and which gets further shaped by nurture, how we are brought up, what's the impact of family, what's the impact of extended family, what's additional community settings, preschool, school, wider community networks. So there is no diagnosis is heard of straightforward diagnosis. One has to take all this component into the consideration. Aspects of child development, it all outlines what are different domains we assess a child in. And I'm going to just speed up through a few slides to catch up. Developmental milestones, gross motor, fine motor, speech and language, personal, social. I've highlighted the things in red which should be red flags. Non-weight bearing by the age of 18 to 24 months. Motor planning, coordination difficulties. Is there dyspraxia? These are my occupational therapy colleagues will be able to help me there. Motor planning difficulties, coordination difficulties, speech and language difficulties, non-verbal by the age of 3 to 4 years. What's going on? Speech pathology colleagues will come handy there. Solitary play, limited interest in joining with peers. So yes, developmental pediatricians will be there, but we all pull out information from allied health colleagues, preschool, what's going on. How do they present? So generally, in the first year of life, infancy, the common symptom parents will come to you in the clinic is, doctor, my child isn't talking as compared to my friend's child. His child is not walking. So first year, it's locomotor issues, and generally, it's in the toddlerhood when there's low language acquisition, behavioral challenges, and then comes school readiness issues. So in the first year, commonly are neurometabolic issues, then comes possibility of either isolated language delay, inadequate environmental stimulation, and global developmental delay. And then becomes, okay, child is not ready for school. Is it significant disability or isolated individual domain issues? Then comes school, early primary, late primary, academic concerns, attention span, compliance, behavioral challenges, and I've written differential diagnosis. One, whether it's just a variation of normal. Is this a migrant child who doesn't know English, who just landed in the country, or is this a child who hasn't attended the preschool at all and is straight in the school having challenges? Or is this a child with intellectual disability who hasn't attended any services and these disabilities are getting more apparent? The more closer to normality or variation of normal, those issues go under the radar. Those obvious severe to profound, they do come into attention quite early on. What's the approach? Is it variant of normal or their real concerns? See, what should we do? seek assistance, and what can we do in terms of etiologic workup. So take home message is any concern coming from the family, yes, one needs to reassure, but always what can I act on? Where can I link these children to? I've just put in this slide ages and stages questionnaire, which screens development across different domains. What's the approach? Therapy input. Yes, there are multiple therapy options available in community health and private sector. And one has to judiciously balance what is the priority. How can I link this family into socially? Playgroup, mothers group, preschool attendance, and Raising Children Network is a very helpful website for parenting support. Supports to the family, that's where the role of GPs will be, or any other. What is the impact on parental emotional well-being? Workforce participation. Are there financial hardships? These are Medicare rebate plans. I don't need to talk about it. NDIS, I think all of us are all over it. I just need to highlight it. Early childhood, early intervention. One needs to know for children 0 to 7 years, we can directly refer to ECEI. Life Start is the agency. And one doesn't need to have a diagnosis for accessing NDIS, especially under ECA. I know we always get bogged down by is the child diagnosed, but for 0 to 7, the concept is any developmental domains issue, allied health report, preschool report, please contact Life Start. Do not wait for assessment or a pediatrician appointment or the children sitting on the waiting list. Straight start accessing therapy. It does make a difference. Diagnosis will evolve. It's a journey. What's the clinical approach? What's medical? We need to monitor these children's growth. Dietary issues. Yes, definitely. They need assistance. Is there a dietitian need to be there? Sleep issues, common basic sleep hygiene. Is the child constipated? Is the reflux there? Seizures management. Obviously, it will come to specialists, but has it been looked at? Hearing, vision, screening, dental, immunization. Is the child immunized or parents have chosen not to immunize due to concerns regarding ASD, autism spectrum? That can be another topic of discussion. Educational supports. Is the child linked with educational support? Preschools can apply for inclusion support funding. Early intervention unit is a Department of Education school readiness program, transition to school and school enrollment. Approach to school early. Don't leave it till last. We always tell families. This is transition to school form, which could be forwarded by parents' signature, by any involved clinician, and the parents can, the school can know as early as they can so that they can plan supports. What are the educational supports? As either the child can be in the mainstream or the child can be in a support class. And these are the different support classes available. And then is a school for specific purposes. And there are a couple of schools which are there in the area. And these are all public school support options. And then there are Aspect and Catholic schools. Coming to the end, I need to give opportunity to other speakers. So I'll just run through autism slides. I know this is one of the topic of interest and everything looks like autism, but is everything in the spectrum? Our main changes, DSM-4 has moved to DSM-5. Essentially, DSM-5 has comprised two domains, social communication and restricted interest, repetitive behaviors. Previously, language was an additional component. Another additional thing is levels of autism, level 1, level 2, level 3, and it's a functional level. Level 1 means requiring the support. The child or an adolescent or an adult has difficulty initiating interactions, but the level of support is quite minimal. Level 2 are still verbal kids. There are some difficulties with behaviors, but they're manageable. And ASD level 3, these are the children who require significant level of support to keep them safe, manage daily living, and keep them safe at school and in the community. What's the typical age of presentation? I always get asked this question commonly by clinicians. See, in 25 to 30% presentations, it's quite obvious as early by second year of life. It's just by the time they reach the diagnostic stage, they could be 2.5, 3, but that happens in 1/3 cohort. But a lot of different services say generally common age of diagnosis 4 to 5 years. And there is another subgroup which is widening is relatively high functioning autism, which are the children with average intelligence, or they get diagnosed a bit later as well when they present in adolescence, 7 to 9 years. Autism prevalence rising high. This is a US slide, but Australian data says still prevalence is 1 in 100. Why is such a high prevalence? We don't know. But is it something that is diagnostic criteria has become more explicit, or we have become more aware? It is combination of both. And there is also some research mentions about impact of advanced parental age, paternal age, and geographic clustering, especially where there are more diagnostic services available. Obviously, diagnosis is likely to be more picked up. How do we diagnose? It's a DSM-4 criteria. Parent interview, play observation. There are tools, but tools are tools. It is a clinical diagnosis at the end of the day. And formal assessment is a part and parcel, an IQ or cognitive or developmental along with language assessment. How common is association of autism and intellectual disability? 10% of individuals with intellectual disability also have an associated autism spectrum disorder. But when we look at the cohort of autism spectrum disorder, more and more children or adults with average intellect are getting diagnosed with ASD. And that's where I think the pendulum is shifting. Associated gamut of issues, it comes with baggage. Autism is just a spectrum, and no one child on the spectrum is similar to other. That's it, and thank you. And I will hand over to my colleagues, Kathy Sibinis, who will talk to us about impact of a child with disability on a family, and then followed by transition into adulthood. Thank you.
Thank you, Chitra. That was very informative. I'm going to talk about impacts of having a child with a disability on the family. My name's Kathy Sabonis, and I'm the senior social worker who's attached to the specialist ID health team. We're based at St George Hospital, and we have teams in the Illawarra and Nepean Blue Mountains. What I'd like to talk about are the emotional and practical impacts of having a child with a disability, historical implications of people who have disabilities, legislative requirements, family and centred care, person-centred care and family-centred care, and the resources that we can access to support families. So there's a consensus amongst the research which describes the impact of having a child born with a diagnosis of some form of disability. And these impacts appear to be divided into two areas, emotional and practical. The impacts will overlap and vary in intensity over the lifespan of the family. The emotional impacts are things such as disbelief and confusion, anxiety, stress or worry, grief and loss, helplessness and frustration, anger, guilt, chronic sorrow and trauma, and jealousy of typical families. The practical impacts are things like fears for the future, concern about the impact on the wider family, such as siblings, the financial impacts, isolation, poverty, homelessness, the impact on marriages, inaccessibility of services and activities, and the lack of support and understanding from society. Stigma. Stigma has been attached to having a child with a disability across cultures and generations, and as a consequence, the family may withdraw and focus solely on the well-being of the child in their privacy and in isolation. I think the little picture at the bottom is quite poignant, and it made us feel quite sad when we looked at it, but I think it's a good description of how some of our families might feel when they've got to defend their child's behaviour in the community. We still come across families, you wouldn't think so in 2020, but we do still come across families who have chosen to raise their child without the support of services, And when we meet them, they appear to have fallen through the cracks, and they often come to our notice when one parent passes away or one of them is diagnosed with dementia, for example, and they can no longer fully care for the needs of their ageing adult child with a disability. So I'm just going to check my notes to make sure I cover it all. It's frightening and it's sad that in the first half of the 20th century, children with a disability were largely an invisible population. Many families were advised to relinquish their child to institutional care and move on with their lives. And until the 1960s in Australia, families were encouraged to relinquish their children as the only way of getting their lives back. It makes you think as to why many families hid their children from the community. Were they embarrassed, or were they actually fearful of what the state could do to them if they couldn't adequately support their child or young person? Today, thankfully, there's more focus on supporting our families and giving them and the person with a disability better access to the community and better access to positive outcomes and to a good quality life. The Disability Discrimination Act of '93, the Disability Inclusion Act of 2016 and the Royal Commission into Disability of 2019. On March the 1st, 1993, the Disability Discrimination Act was ratified, and Australians with a disability finally had a national law that was designed to provide them with equality in many areas of life. This was followed by the Disability Inclusion Act, which actually built on the Discrimination Act of 2016. They started it in 14, it was ratified in 16. And over the past quarter of a century, these acts have contributed significantly to social change for people with disability. The Disability Discrimination Act was Australia's first federal uniform legislation to recognise the rights of people with disability, and it's been used by thousands of people with disabilities to fight against discriminatory practices in many fields, including accommodation, employment, education, access to transport, goods, services, facilities, and more. The current Disability Act is the Disability Inclusion Act, and there were movements prior to this, such as when in 1981 it was identified as the Year of Disabled Persons, and in 1986 the Disability Services Act was developed. The Disability Royal Commission was established in 2019 as a response to community concern regarding widespread reports of violence against and the neglect of, abuse and exploitation of people with disability. The incidents presented to the Commission might have happened recently or a long time ago, but they were still considered by the Commission as issues that needed to be considered and covered and looked at to improve the lives of people with disabilities. The Royal Commission looked at these incidents, but also looked at avenues of reporting, investigating and responding to reports while promoting a more inclusive society which supports people with a disability. The Disability Service Standards are a list of, I would call, best practice guidelines. So when we provide a service to a person with a disability, we need to ensure that the rights of the individual to decision-making, self-determination and freedom of expression are respected. We need to ensure that whatever we do and wherever we lead the person with a disability, that they have participation and inclusion in the same society we all mingle in. We need to make sure that based on people's strengths, we look at their individual outcomes and we celebrate them. We as services provide an opportunity to build on these strengths and to identify and build on people's goals. We need to make sure that people with a disability and their families have an opportunity for feedback and an opportunity to safely complain and inform service-wide reviews and improvements. We need to make sure that people with disabilities have equal access to services. So service access, so that services are managed in a transparent and equal, fair and equal and responsive way, and that the management of the service is effective and accountable and maximises outcomes for individuals. We promote person-centred and family-centred care, and there's been a move away from institutional care. There's been a person-centred shift in the way a person with a disability is viewed, and the culture around people with a disability has changed, and there's the acknowledgement of the value and the rights of people with a disability within a society. There's also been an acknowledgement and recognition of the benefits of family care in providing support into adulthood. And in this way, we try and support families to continue their role in caring. This is a lovely quote, and we thought it was a really lovely little picture. The success and longevity of care provided by families when a child is born with a disability appears to be based on the success and availability of support around them. We need to remember that on top of raising their child or their children with a disability, parents often have other caring responsibilities, such as other children, caring for family members who may be unwell, possibly caring for their own ageing parents, and holding down part-time or full-time work. Parenting a child with a disability is a multifaceted role. Parents, whether they plan to or not, become part of a multidisciplinary team looking after their child. And parents administer medication, they administer behavioural strategies, they collect data. They're the implementers and they're the providers of social activities and community access. They're the taxi drivers and the referees. They are the advocates and the teachers and the carers of the person that they love. At times, this multifaceted role can take its toll on families. I just want to mention that parenting is a multifaceted role, and one of the dilemmas that we're currently having is the accessibility of services. I just want to read my blurb to you. One of the practical problems is availability of services and access to these. The NDIS, which is growing, it's developing, it's honing, it's becoming very user-friendly, it's becoming useful, and we're learning how to make it work for our families. The NDIS has created an opportunity where allied health professionals can tailor their approach and focus solely on people with disabilities. For example, occupational therapists who are specialists in sensory issues, or speech pathologists who can assist with chewing and swallowing issues or alternative methods of communication. While the NDIS is in its early stages in New South Wales, there are limited numbers of such experts. But with time, this will hopefully improve, making specialist therapists more accessible and reduce waiting lists. If we consider the combination and the overlap of the practical and emotional impacts, it's clear that there are multiple variables affecting stress and not necessarily the diagnosis of the disability. Disability may not be what families sign up for, but for many families, disability may not be what families sign up for. But many families argue, and the research supports, that raising a child with a disability has the same responsibilities as raising a typically developing child. It is first and foremost a parenting role, albeit on steroids. As their child's advocate, families must regularly fight to get services to be seen and to be heard. At times, the information they provide may not be accurate. To get services, families may often exaggerate the dilemma or the situation. To avoid humiliation, they may reduce the impact of the behaviour or hide some truths. We need to forgive them for this, and we as clinicians need to be comfortable with the topics which can cause grief to parents, and we need to be really good at asking the right questions. It often takes immense amounts of courage for a parent to seek help and to verbalise their fears or failings, and it's often the GP they may turn to for support. When speaking to families, they've said to me that caring for a child with a disability can be thankless and relentless, but the successes when they come are amplified and boost the confidence and well-being of both the carer and the person with the disability, and give them access to reserves of strength and patience they didn't know they had. Behaviours of concern. These were previously referred to as challenging behaviours. And this is a lovely quote too. It appears that factors such as communication difficulties and behavioural problems rather than a particular diagnostic group predict stress. Providing physical care may be less stressful than supporting a person with behavioural problems. Behaviours of concern are not restricted to small children or small children with a disability. As children grow, the behaviours of concern can increase and are more difficult to redirect or to physically manage. This creates a myriad of issues for families who may have other smaller children in the home, or problems for the school where there's a duty of care to protect both the student with the behaviours and other students. Or the day placement, where adults may display behaviours which distress other participants or place everyone, including workers, at risk. The threat of suspension from school or day placement because of behaviours of concerns causes great distress to carers of people with a disability. Puberty. Puberty is a horrendous time for parents and young people. A young person with a disability who's unable to communicate may struggle to identify what they're feeling, and this will present itself as a behaviour. A child or a young person with cognitive deficits may struggle with receptive communication and may be less able to regulate their moods and behaviours, which leads to escalation and potential aggression, which may cause harm. Parents are regularly concerned about the introduction of medications and side effects, and some avoid introducing medication for as long as they can. Behaviours of concern are very often part and parcel of a child with an intellectual disability or ASD prior to puberty, and regardless of the age of the child. It can be a means of communicating. We don't need to look at the research, however, to understand that puberty and adolescence can turn the meekest, mildest child into Darth Vader, regardless of whether they are typically developing or not. Puberty is often accompanied by behaviours of concern, which rock the most steadfast of families, and conversations about behaviours may be difficult, and parents may find these behaviours as their own failures. Medications may need to be considered to enable the child or a young person to access the community safely and engage in quality of life. This can be a difficult conversation for parents and carers. Let's have a look at a case study. Miss Millie, who's 13, has a diagnosis of autism spectrum disorder level 3. She has an intellectual disability, which is severe. She's non-verbal. She lives at home with mum and other siblings. She attends a local SSP, which is a school for specific purposes, and she attends after-school activities. There is no previous history of behaviours of concern. But within the last 4 weeks, Miss Millie has become crying and screaming when in the family home with no clear trigger, and this has not been happening at school. Mother reports behaviour to be difficult to listen to and confronting, and multiple complaints from neighbours have come threatening to call the police and the strata regarding the noise disturbance. Millie has attended her local GP, who can't identify an organic cause. When we visited the family, we felt very sorry for mum. She described feeling guilty and defeated. What we tried to share with her was that the difference between home and school is that school there is a number of staff to redirect Millie's behaviours of concern before they take hold. The staff are able to implement strategies because they rotate amongst themselves, and they're better able to provide consistent messages and are not overwhelmed or saturated by the behaviours. At school, the young person can access a variety of environments. Teachers aren't sleep deprived necessarily, and they're able to debrief. They get to go home, and nobody's threatening to end their tenancy with threats of the body corporate or the police. When we talked to mum, she said it was awful to hear her child so distressed, and she felt ashamed for not understanding the purposes of the communication and for not being able to calm her. In this instance, the help of a multidisciplinary team as well as a medical team was enlisted. So something to think about. Families who aren't familiar with the services available will often seek the support from the GP. Not being able to cope, an overwhelming sense of grief or chaos or sheer exhaustion are some of the often very difficult conversations for a parent to have. The GP is often the holder of the history and the one reliable, consistent and safe resource. We encourage families to look after themselves so they don't go under, and we encourage them not to be superheroes and to accept support. Although the person with a disability will present to you as the patient, the carer may also be desperate to be heard. So family and person-centred care. So in terms of how to support a family caring for a child with disabilities, always think person and family-centred. Be holistic. Look at a multidisciplinary support. Do we need an OT involved for sensory issues? Do we need a speechy involved to assist with communication? Does a psychologist need to become involved to develop strategies to help a child self-regulate? And we need to be aware of constantly changing needs. Is mum being threatened with her tenancy? Is dad's job at risk with COVID? Has Nana gone into a nursing home and mum's sharing her time between the child with a disability and going to a nursing home? What is going on for this poor little family that we can possibly support them with? And not only do we provide support, but we want to help families to help themselves. We want to encourage families to accept support, to accept help, to seek support, to seek regular therapy or counselling, and to consider joining support groups. I guess too, we need to acknowledge that at times it's a really tough gig to be a parent. So just to sum up, before we go on to the resources, just to sum up the impact on families who have a child with a disability, the impacts are wide and varied, but they can be identified as emotional and practical. Families may feel that there is a stigma attached to them. Puberty may be a particularly difficult time, and families may need additional help. Behaviours of concern are generally very distressing for families and people with a disability, and they're not restricted to puberty. Behaviours of concern can occur throughout a person's lifetime, and it may be a way of communicating that something's not okay. So the resources to support families are the Carer Gateway, Young Care in New South Wales for young people, the NDIS to provide funding to link people into services. La Trobe Community Health is the provider of the LACs and the planners who talk to the families and redirect, and assess their needs. The phone number is just below. And the Disability Advocacy Service is where parents need additional support or need someone to help them fill in forms or need someone to speak on their behalf. Carer Gateway replaced Carer Respite or Carers New South Wales, but continues to be funded under the Benevolent Society, and La Trobe Community Health actually replaced St Vincent de Paul's. How am I going for time? Okay, for time. There's a little quote here that says, that came from a woman, who wrote The Memory Keeper's Daughter. And she said, what would happen, they conjectured, if they simply went on assuming their children would do everything? So not giving a child a label, perhaps not quickly, perhaps not by the book, but what if they simply erased those growth and development charts with their precise constricting points and curves? What if they kept their expectations but erased the timeline? What harm could it do? Why not try? I wanted to just talk to you just briefly in terms of the impact that having a sibling with a disability can have to their brothers and sisters. And I just wanted to say that siblings, as Dr. Chicha mentioned, siblings children have their own personalities, and their age will impact on how they understand what's going on. Children are resilient, and we place them in challenging situations throughout their life. For example, the introduction of a new baby set my toddler off onto off the Richter scale. So the introduction of a new baby, the first day of school, the last day of school, the death of a grandparent or a friend, separation and divorce. Children are faced with these complex situations throughout their lives, and they follow our lead. They follow the lead of their family, and they experience all the general feelings as other children do when faced with complex situations. They experience fear, grief and distress, resentment and jealousy. Children often step up and assist with parenting, and they defend their sibling and their parent from grief or physical abuse. They have a tough gig too. My opinion on how they survive it depends on their ability to feel loved, to express their concerns, and having a sense of place within their families. Thank you. I pass you on to my colleague, Dr. Asma Taskin.
Good evening, everyone. I'd like to thank both Chitra and Kathy for your nice and informative presentation. And I also like to thank Paula and Jenny and everyone else who were involved for the last few weeks organizing this lovely event for everyone. And I also like to thank everyone else on the other side of the screen who are attending this event after a long day of work. So, and I hope I will not bore you with my presentation. So my topic is, I'm Dr. Asma Taskin. I'm the rehabilitation staff specialist with COGRADAS and the new SEED team. And my topic is talking about transitioning to adulthood for people with like developmental and intellectual disability. So the topics I will try to cover is just give a bit of idea about what is transition, importance of transition, what are the differences between adult and pediatric service, what are the stages, what I do in my transition clinic, how to plan, and then if I have chance talk about our model of care that we follow. So medical transition is just the definition. You can see the reference there. It is the purposeful planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to an adult-oriented healthcare system. And why it is important? There had been lots of research that showed that the current existing health system does not generally manage this period well, because there is lacking of well planning, effective coordination during the whole process, and that eventually causes poor health outcome and crisis presentation in the emergencies, and then eventually they become reluctant to access any sort of health services. And why we want a smooth transition? Because with a well-planned and properly implemented transitional process, we can expect that young adults will maintain their health and quality of life. And it will help them to continue to use healthcare service appropriately with the following. We can expect better functional outcomes such as increased adherence, improved self-management and knowledge of their condition, and improved well-being. We expect to have better access to appropriate health services for them, for those who have chronic conditions. And then we expect to improve morbidity and mortality rate and reduction in avoidable hospital admissions. There will be some still unavoidable admissions because we know that most of the time they have other problems, mental health issues. So this is comes like a lot of parents and sometimes some of our colleagues will ask, what is the best time? It can be a bit controversial. So the literature suggests that the discussion should begin at age of 13 because it will allow enough time for planning. But in practical life, you understand it is difficult because they are at school and they have lots of medical issues, sometimes behavioral issues, and sometimes parents are too overwhelmed. And sometimes there is a bit of denial as well, and they don't want to do it. They want to just put it away for till the last moment, like all of us. We do sometimes. But normally, practically, in my clinics, I start seeing them at age of 16. I'm an adult physician, so I see from age of 16 and onwards. So first of all, I like to mention the differences between the pediatric service and the adult service, okay? Because it's like, you know, you are having very five-star level service when you are under the pediatricians because they provide the service as it's family focused. And in the adulthood, it is very big community and it's very difficult. So it is mainly individual focus. So we just see one person and it is based on that person's problem. Consultation and questions are asked in the pediatric service to carers, families, parents. In the adult service, we expect only most of the time the patient to know about the problem, or just if they're severely disabled, maybe the carer. The appointments are more flexible in the pediatric service, but in the adult world, unfortunately, the adult doctors, it's difficult for them to take the responsibility. It is also like empowering the person to take responsibility, because after 18 they become adult. So if they miss any appointment, if they have to cancel any appointment, reschedule, all these things, it doesn't come from the clinician. It needs to be initiated by the patient or his or her carers. Whereas in the pediatric service, they will actually contact and reorganize and do a lot of things for you. And yeah, pediatric service is less expensive than adult services, because adult services, mainly the specialist services, it's not available in the public system. You have to go and see them privately, and it costs money. I'll tell briefly about stages of transition. So the early stages are 12 to 14 years. Middle stage is 14 to 16 years. So the early stage is like you just get them ready and prepare family and the person that, okay, there will be some changes coming. 14 to 16, you really need to sit and think about your goals, and you start to think about what you want to do when you leave school or in your future life, about education and other things. And then 16 and 18 years is the most important year, because that is the time, literally, once you turn 18, you're gonna considered as an grown up, as an adult, so grown up adult. And after that, it can vary, but once you turn 18, most of the pediatric service will stop. It may vary in private sector, but in the public sector, you cannot get admitted into children's hospital anymore. Now, we will discuss the issues of transition in different stages. So we try to think about self-advocacy. So I mentioned before, we need to think about specialist hospitals, what are the community services available, and then we need to think about, like, you know, in the pediatric service, we have the pediatrician who covers most of the problems, and I have seen patients who hardly have seen their GPs, because everything they get done through their pediatrician. They're very nice, they're very helpful, and once they turn 18, and they even, the first time they're going, not maybe first time, but they are going to see their GP after a long time, and they really don't know. And you know, a GP practice can be very busy, and so there is a quite bit of difference. So so we want self-advocacy. So through this transition process, we teach them that you have to own, have the ownership. So I'm talking about the mild ID people. Definitely it will not be appropriate for severe ID, but still take the decisions about where you want to go, who do you want to see, discuss options for accommodation, and also if they want to you know, join any peer support group, internet, all these things, it's also possible. And then independent healthcare behavior, like, you know, taking their medications. They need to know what are they taking, what are the effects, if there are a problem, who they need to contact. So they need to have their doctor's numbers, and they need to know about sexual health, because some of them in future, they might want to have families. So they need to know about the genetic risk, sexual capabilities, fertility, all these things, family planning. And New South Wales family planning actually have a range of resources to support these people. And I keep repeating that I'm talking about people with intellectual disability. Chitra has mentioned, like, you know, mild, moderate, severe, and profound. So I'm covering the whole range. So some of these may not be appropriate for severe and profound intellectually disabled people. So, okay, so some information about Ashfield office. They have a family planning office there, and they are really good resources. They run some courses and some sessions, and those are helpful for some people who are interested in all this information. Then we try to cover the psychosocial things as well. So, which is discussion about mental health issues. A lot of the people with intellectual disability have associated mental health problems. They need to know what support is available in the community. Okay, and then about the social activities, recreation, all these things, health and lifestyle. So if they are living away from their family, whether they need a bit of, like if they have some physical disability, whether they need any assistance with that, or if they need help with some housework or anything else. And then educational and vocational planning. So at school, from school, the teachers will be aware of the strengths and the capability of their students when they're in year 11 and 12, and parents should be doing it with their children, like the child, and even family members can be involved, school can be involved. If they are already an IS participant, they can involve the support coordinator and make a plan. And some of the school have school counselors and transition teachers. Okay, so, and I will talk a bit more details about educational and vocational planning, and then also parents need to understand, this is important, like, you know, sometimes what happens, particularly with mild intellectually disabled people, when they become 18, they have been looking for that time and that birthday because they know that now they are adult and they can make their decisions. So here it comes like whether they have capacity or not. If they have capacity, which is a different thing, like we need to assess at the time, but sometimes they want to make their own decisions, and it's difficult for the parents to back off and let go of these things because they have been looking after their kids since they are born, and then all on a sudden, if they want to just become independent and do things on their own, there's fear and there is uncertainty. And like all of us, we have problems, like, you know, first day at daycare, preschool, first day at school, as I think one of my previous presenter mentioned, Kathy. So these are the important days. So we all face that, and it is a bit challenging for people with intellectual disability, and it's difficult for parents as well. But so parents and family members, they need to understand, like, we have to respect if my child has the capacity and if they have understanding, and though sometimes you have to just weigh the and balance the way of risk versus, you know, how much risk you're going to take, basically. And then sometimes we need to talk about guardianship. Now, this is a slide I have taken from SEI. So so it just says how, like, you know, what is the formal transition process. So so you have early preparation, then you do the identification of a transition coordinator or facilitator, which can be from school, and then you need to have good communication. Then everyone's transition will be different, so it will be individual plan, and it's not like a generic formula that applies for everyone. And then empower, encourage, and enable the young people to self-manage, and then you have to do follow-up and evaluation. Now, then the transition process is actually, it's a big thing. It covers the medical issues, functional issues, and then you have the psychosocial thing. As I said, like whether you want to continue to study, you want to go to a program, or you want to go for work or employment. And then also, where will be your future accommodation? Then the medications or therapies. So this is very vast thing, and normally like it cannot be managed by one sort of setting. So you have to have few discussions. Then also identifying a proper GP, then arranging follow-ups, and giving the transition. Like we do have a transition book that was developed by one of our transition teacher in our LHD. So and that has a lot of information. So we normally give the family the transition pack. So one clinic is too overwhelming for them. So if you have something in writing, when they have a bit of time, then they can sit and go through all these things, because it's very difficult to remember everything. Now I'll focus on individual things I mentioned. So medical issues. So in my clinics, most of the time, like, you know, we have the GP referral letter. We know what are the medical problems. In general, normally this population has some comorbidities. There could be neurological problems like epilepsy. There could be gastrointestinal problems, which can be just as mild as reflux or constipation, or severe things. If they have swallowing issues, sometimes some of the patient may need even peg feeding. They have lots of behavioral issues, which could be only from the disability, or we have to remember that they may also have mental health issues, which is separate, which can be separate from the individual developmental or intellectual disability. So they can have respiratory problems. Most of them can have sleep apnea, gynecological problem, excessive bleeding, problem with periods, endocrine problems, and rehabilitative problems. So basically, one pediatrician might manage the simple problems, and sometimes if they have other specific problems I mentioned, they go to specialist pediatrician, like, you know, pediatric neurologist or pediatric gastroenterologist. So in the transition clinic, we need to identify what are the specialists they have been seeing in the pediatric life, and then we have to, because after 18 they might not be able to see them, so we have to do the transition to adult specialist doctors. So it is difficult, like, you know, once you turn 18, now goodbye to the pediatric doctor and just turn up to any of the adult specialists. So we want to make it smooth for the family and the patient as well, because if they, most of the time they have problem with anxiety, they have problem with behavior, and the fear of meeting new people, and they are not confident. So from the age of 16 to 18, they need to start talking to their pediatric specialist and identify an adult specialist where they want to be transferred or transitioned. Same for dental care, eye care, hearing. Luckily, sometimes with eye and hearing, it's the same service. It's not that specialized like pediatric and adult, but some of them you definitely need to think earlier and start a gradual transition. In our LHD, actually, Trapeze helps us a lot. They help us, particularly our transition team, with the medical transition. So they will organize, identify the specialist doctors, and then they will make appointment for the family, and then sometimes the first appointment they actually go with them. So I really want to mention that, because this is a great help for the family who really need that. And then also identifying a good GP who has interest looking after this kind of patients, because sometimes like from my practical experience, that it can be too overwhelming for a new GP who has just freshly graduated, and then if he or she has to look after any patient with that this type of population, they can find it a bit difficult, and it is normal, because possibly they have not had exposure to this kind of situation before. And then also organizing blood tests can be challenging for the GPs and the families. But it is also important for patients who are on specific medication that requires frequent blood tests. Now, the physical issues, it also depends on the diagnosis, but they can have problem with mobility. Some of them may have none. Some of them could be wheelchair bound. So we need to just think about where they are at that level and facilitate the adult service for that. Then weight is another important thing. Because of sometimes because of the medications, they gain weight, psychiatric medication, epilepsy medications. Sometimes it just happens because they don't do a lot of physical activity. We have to think about falls. Some of them, like cerebral palsy patients, if they are mobile, they could be at risk of having falls. We need to see if they have problems with spasticity, if they need orthotics, and then in the rehab setting, we identify what else or what other allied health specialty they need to be involved. And then another thing is the functional independence, whether they can actually look after themselves, whether they can brush their teeth, whether they can feed themselves, whether they can shower and get dressed on their own. So that's very basic level. And for people with mild problems, whether they can actually do the domestic tasks, some life skill, then simple things like, whether they can go to the restaurant and order coffee for them, whether they can follow a shopping list and buy things and then get the correct change from the shopkeeper, whether they can travel from one place to another. So these all things we actually discuss, we need to think, and these all are practical. We do on day-to-day basis, but most of the time we may not think about it. And then the big important thing is psychosocial issues. So just think about every stage of transition. If not like other people who do not have any disability, in general, everyone has problem, anxiety. We may have stress, behavioral issues. So it is important to understand that we can express and we can seek help, but people with developmental and intellectual disability, they are too shy. Sometimes for non-verbal people, they cannot express themselves. Some people have communication issues. They will not be able to express, and they will, just going back to Kathy's case study, we have discussed, like someone screaming or having behavioral issues all on a sudden, it could be a lot of things. So we need to think about whether any environmental or psychosocial issues are causing all these things. This population are prone to get sexually abused. They're very vulnerable. So if we, so that's something to think about. And then future planning for education, employment, recreation, applying for any sort of pension, companion card, taxi subsidies, all these things comes in the psychosocial factor, and individually we need to talk to family members about it, and also when the person is able to participate, they need to understand that they have the right to make decisions. So how do we plan? I think I have already mentioned that who will be involved, so I'll skip this slide. I'll skip few of the slides here. Then I'm talking about just elaborating few of the things like, accommodation. What is available? So there are independent living units, like, possibility of living independently. Sometimes they can live with their family and they can live in the care facility. Then they have to have, if they go to any facility or for therapy or anything else, they need to explore about what is available in the community, like what services, what organizations, what agencies. So at school, when they're at year 11 and 12, some of these organizations run some expos, and we strongly encourage the families to go there to know what is available. Unless they know about it, it's difficult for them to make the decision. So the sooner they know about it, then it's easy for them to go and individually visit those places and make the decision. So for post-school options, some people will consider studying further. They will go to TAFE, and the family and the student need to be aware that there will be a person. So it will not be as supported as school. So that's the difference. You know, at school they have the support, very supportive environment, but in the community, once they turn adult, they only have, like in a TAFE, like one facility, they might have only one person who will be guiding and provide some support, but it's not like, you know, there will be only 3 or 4 students and one person will be supporting them. So it's like bigger population and less support. I will skip this as well because it says bit details about how they support that. Then I'll talk about employment. So I don't know whether you are aware of this SLHD program, School Leavers Employment Support. This is funded by NDIS, and this is a 2-year program. Most of the schools, the special schools, run some work experience when they are at year, I think they start from year 10, if not 10, 11 definitely. And then followed by this program, if they have capacity to do some job. So this is one option. And then there is, like, you know, supported job support. So job support is the other thing. So either SLHD or job support. These are the 2 things available for people who are interested doing any sort of proper job. They help them making their CVs. They take them to different type of opportunities for a few weeks so that they can test different jobs and they can figure out what really is suitable for them, whether the environment needs to be suitable for them and they need to like the job they're doing. It's not too boring for them. Then with employment, another important thing is travel training, because most of the time, like, you know, of course, if parents can take them to the job, that's good. SLHD program actually does the travel training. It's part of their program. So they, with training, some of these people can actually individually travel from their home to workplace and work to home. So sometimes it could be just road safety rules if they have to use public transport and then from one stop to another, or sometimes they just provide support for few weeks and then gradually withdraw the support to see if they can manage it. And most of the time with training, they can do it if they're in the mild and moderate range. And also they will get them ready for work. This website has some information for the work readiness. I'll let you have a look when you have free time. These are the skills someone needs to, you know, some social skills. It is important to keep the job, because sometimes the person are good doing the job, but they don't have the social skills, and that can create problem with the other people around them. And this is same as well, the social behaviors. Now, the other post-school option for people who cannot go to TAFE and who cannot go to job, like any sort of work experience, some of them with severe to profound range, they have to, for them, this facility is available called day program, and NDIS will fund for that. And also same, parents can get information in those expos, because they will market for their day programs, the agencies and organizations, and we encourage the parents to take their child to the specific day program they think they like, or not only one, maybe few of them, and then actually they figure out whether the environment is suitable for their child. It is another important topic and big issue during the transition, friendship and relationships, because they have studied in the same school for maybe 10, 12 years, and they have this known environment. And when they go out of this big community, like, from this safe and supportive environment to the big world, so for some of them, it's very difficult. They miss their friends. It's difficult to make a relationship. And I mentioned before, they are not aware of stranger danger, and they can be very vulnerable to get abused. So there could be some, like, rather than going into much details in my slide, the speech pathologists and the psychologists can actually make some social stories to help them give a bit of idea about stranger danger and maintaining friendship and relationship. And sometimes I have seen at school, actually, they do this. Some of the teachers are very good, and they will specifically make one child sit to a different child each week and make them do some practice conversation, like, how to start conversation, because some of them, they don't know how to initiate conversation and maintain that. So this type of practice can help them with social conversation. And for people who really struggle with speech problem and have communication problem, speech path can help with the devices that are available, and that can be helpful. Yeah, as I said, just the script of a conversation they have to practice. And then I already mentioned about the accommodation available, and it's just the parents' decision for future what to do, but it's important that they know about the options available for future. And then the life skills, I have already talked about all these things. This is another important thing for like until they're 18, everything done by the parents or the carers. And once they're 18, there are legal issues. So if they don't have capacity, parents may have to take legal guardianship, like formal guardianship, and they may have to have the power of attorney for financial management. And parents need to be aware of that. Depends on the situation. It can vary, actually, whether sometimes they will only take the guardianship but not the financial authority. So it depends on the person's disability level of ID or IQ problems. And of course, if there are conflict, there are options. If there is no one in the family to be guardian or making decisions about money, then you have to have like public guardian or trustee, public trustee. Then it is important to know about companion card. And this is the website where you can actually get the information. So basically, companion card is a card if a person with disability cannot go to a place, it's not safe for them, like a music concert. If someone enjoys music and the person is not capable of going to the music just by herself or himself, if you have companion card, the person or the support worker can go with them as a buddy, and they get to go there free. Then whoever is looking after the person gets carers payment and allowance, and these are the websites or links where you can get more information. Like, adult people, you can get mobility parking scheme application or taxi subsidy as well. And these are the information you can get from this link. This is another important thing. Because most of the time, once the child is born or baby, like someone is like after newborn, we do get enrolled, and government has all the details. So what happens sometimes, if the name is listed in the Electoral Commission, once they turn 18, you need to specifically seek for exemption. Otherwise, you have the risk of getting fined. With mild and moderate intellectual disability, developmental problem, the person may choose to go for voting, and that's their right. But if it's very obvious that they don't have really a capacity to make any decision, then they need to get exempted. Medicare card, healthcare card. Normally, Medicare card can be under the parents up to age of 25. There is a rule that after 25, they have to have their individual Medicare card. It's just very simple, just they have to apply for it. Enhanced primary care. I think most of the GPs are aware of this, so it is important that they have that done. Few of the allied health professionals or service that can be covered through this. That for mental health problems, I think through a mental health care plan, 10 of the visits to a psychologist can be covered under Medicare to the appropriate providers, from the appropriate providers. And rather than talking much about NDIS, I will just leave this slide here, some links here to get more information, because it is a big topic and cannot be covered. Through NDIS, they can get like the day program funded, SLHD program funded, and allied health treatment or therapy funded. It should cover the equipments as well. For people with who are too overwhelmed or who have multicultural background with poor English, I normally recommend them to have a support coordinator, because they can get a bit of extra help organizing things for their young adults. Headspace is for people with developmental or intellectual disability who has mental health issues. So it also covers the alcohol and other drug services as well. This is another important topic about short-term accommodation, previously known as respite. So my colleague Kathy talked about the impact on families and siblings. She mentioned, they need to debrief and they need to be listened to. One thing is important, that the main carer of child or young person, it could be the dad or mom. Often they forget to look after themselves and they don't take a break at all, and they really need help. So they have the guilty feelings. They will say, I cannot imagine, like, it's my duty, my responsibility. I looked after my kid since he or she was born. How can I let him? They don't feel comfortable. They are scared. They hear stories about short-term accommodation, abuse and other stories. And it is a big step for them, but they really need that. And it is like our duty to encourage them. And sometimes I try to frame it that it's not for you, it's for your young adult, your child here. They need a break from you. Because you see, the teenage boys and girls, they go for sleepover. And that's normal. So why people with disability will not have this facility of having sleepover? So if I frame it that way, sometimes they get convinced. It is difficult to take away the fear, and any fast step is difficult. So these are the links for respite. And I'd like to mention that there is another facility called emergency respite. If something happens to family members and if they have to go to the hospital or emergency or something happens, there is one emergency number. I don't know whether I have this number here, but that is important. And they will organize immediate respite if there is a need. Okay, so ACI has this transition care network, and a lot of information I have here at the beginning I actually took from ACI website. These two are also, and also Trapeze, they are working together. It is very helpful. Lots of information for health professionals. And then for carers, some benefit for carers, like some of the carers are not even aware of the things they can access to. Sorry, my slides are going on and on. So admission to discharge is another toolkit, which is when people, particularly it's for family home and sometimes for group homes as well. If they have any specific things we need to know, like what are they allergic to, if they have problem with noise. So top 5, so in from admission to discharge, we create a folder with some information. So when they go to hospital, then they have those information. And another thing is top 5, like identify top five things that is very important for your young adult, so they can take this to hospital. And then, because sometimes they cannot talk, like for nonverbal or behavioral issue, so if someone have a look at that, okay, this child has problem with noises, so try to reduce light, noise, this kind of information. So this is the family planning website. And then this is, I think, my last slide. So, sorry, I was rushing. Yeah, sometimes it is difficult to get blood test, get immunization, do some specific test. This is particularly not related to transition, but I thought I'll just put up this one. So about cervical cleaning, about having a mammogram, about bowel screening. So these are really some nice, they have the pictures, then they describe things. So maybe someone has to sit with the person who is going to have this test and explain. And the pictures are very, very visual, so they will understand. So sometimes if they have to go to the doctors and they don't like, then just preparing them, showing them, that the doctor may put just a cuff around you to check your blood pressure, all these things. So if anyone has time, you can actually go through this, and these are helpful. So last one is checklist for transition. So we need to make sure that they are attached to a GP, if possible with knowledge of disability. We need to make sure that we have covered the post-school options. We have planned, explored, and identified. So by the age of 18, I want them to identify whether this person is going to work, any SLHD program, employment, studying, or going to a day program. And if day program or employment, where is that? They should have some idea where it is they are planning to go. And that need to be based on where they live, whether there is public transport available or not. Sometimes the day program provides the transport, so depending on all this. Then, of course, as I said, the medical professional engagement need to be commenced before age of 18. And then they have all the numbers and they have all the records from the previous pediatrician, like what if they have had any orthopedic surgery when they were a child, whether that person had spasticity, been to a spasticity clinic, has Botox injection as a child, because these are all important information need to be known to the adult specialist doctor. Then we need to make sure they have, when appropriate, sexual health education, mental health. We talked about their recreation and leisure plans. I mentioned about the transition booklet earlier. So that one covers a few of the leisure activities and the address where they provide that, because there are dancing groups, there are music groups, there are swimming groups, there are some clubs where I'm aware of a club mainly for autistic kids who can go there and talk to people around their same age and do activities they like. And then another important thing that, there are different service providers available, and by the age of 18, before they leave school, they have identified who are they going to stick to. And if they have any chronic illness, they have a management plan. And then we need to make sure they have a support group, because once they leave school, that supportive environment is gone. Some of them may still contact the transition teacher or counselor at school, but they only can support first few months after they leave school, because they still have to look after their own students at school. So that's why it's important that they have identified, like the mom and dad or the carer have identified, or sometimes what they do is in year 11 or 12, because in a specific school, wherever the student is going, there are similar parents, and they sometimes create their own group, and they talk to each other and they try to support each other. So peer support group, that is important. And in some cases, you will need a case management type of thing, and make sure that is organized. And these are the references. So I think we're supposed to answer some questions. Questions? Oh, one more. Sorry. So this is the contact. Should I just? And thanks everyone for staying with us, and we are happy to answer any questions. So we'll ask Jenny.
Thank you, Asma. Informative presentations by yourself, Chitra and Kathy, and lots of important topics and information covered in the presentations, including life skills and employment. I think to the enjoyable series that I've watched, Employable Me and Love on the Spectrum, both great watches, both a great watch. We've got a couple of questions here, and I'm conscious of the time. We've got one question here. Where can I refer the family for accessing therapy support for their child with developmental concern?
Jenny, voice was breaking, so I would clarify. The question was, where can I refer the child for therapy for developmental concerns, correct?
That's right, that's correct.
Yeah, it depends upon, see, the services are wide, and that's a maze, and that's why unfortunately there is not sort of a one hub, but it depends upon what's the age of the child, where do the family live, and especially if in the public services there are services, speech therapists, occupational therapists, psychologists, St. George area and Sutherlandshire area. If this is what we are talking about, some other services are in Croydon Community Health Center, if we are talking about Sydney LHD. So yes, there are community health services in public, and there are multiple private sector providers where the families can access under Medicare rebate plans organized through GP, or referral to ECEI, early childhood, early intervention provider, where life start, and they are generally able to help the family through.
Thank you, Chitra. Well, one more question we have time for. What do we do if a parent visits and can no longer cope caring for their child with disability, or if an ageing parent can no longer care for their adult child with intellectual disability?
No, thank you. I'll hand over to Kathy for that question.
I think there's always a time where it just gets too hard. I'll start with the adult person, because often the person...
For taking the time to present tonight. Thank you to everyone for attending. You will receive the evaluation link in your email inbox shortly. To complete the evaluation, certificates will be then provided in 2 weeks. Additionally, as a reminder, we have one more at the final in this session, and that'll be session 4, Tuesday the 17th of November, Health of People with Disability, focus on complex health issues. These sessions are advertised on our website and web page, so we do have the recordings of our prior sessions on our intellectual disability webpage. So thank you again to all the speakers, and good night. Thank you, everybody.
Thank you.